Yeah, but my camera's off and my mic, so I'm just listening. Oh no, I'm not doing any talking. It's just they're talking to me, but yeah, no, you're fine.
Okay, it looks like we have, well, are we missing Heather as far as the speakers go? Okay, we see everybody. Well, let's go ahead and get started. Welcome to the second day of the Virginia Association of Local Human Services Officials Fall Conference. We have really wonderful panels set up for today. The first one will be on the Marcus Alert, and at 11 we will talk about Unite Virginia, and then this afternoon we'll have a presentation about marijuana legalization. So before we get started, I do want to ask if everybody who's not a presenter to please keep your mics muted. And we will also ask that you put all of your comments in the chat box and your questions. And I'm going to go ahead and turn this over to Ven Thomas. So Ven, take it away.
Good morning, everyone. Sorry, I'm having some technical difficulties. Hopefully you can hear me, and in a moment we'll be able to see me as well. Good morning. I hope everyone is doing great. We are excited for the second day of our VALHSO Fall Conference. My name is Ven Thomas. I'm the director of the Human Services Department for the City of Newport News. I'm also a member of the VALHSO board and the chairperson of the Hampton Newport News Board of Directors for the CSB. It's my pleasure to introduce our panel for our first session this morning on Virginia's Marcus Alert initiative. We have Ms. Angie Hicks, who is the Deputy Director of Behavioral Health Development Services for the Virginia Beach Department of Human Services, and also with the Virginia Beach Department of Human Services, we have Ms. Eileen Smith. Also joining us from Prince William Community Services are the Director, Lisa Madrone, as well as the Deputy Director, the Program Manager of Emergency Services for Prince William County, Ms. Heather Baxter. Next, we have Dr. Lisa Jobe Shields, who is the Deputy Director for Community Services for the Division of Community Behavioral Health with the Department of Behavioral Health and Developmental Services. And last but by no means least, we have Harvey Powers, Division Director for the Law Enforcement Services Division, Department of Criminal Justice Services. Welcome, panel. We look forward to hearing from you today, and we shall get started. Implementation of the Marcus David Peters Act. State and local updates will be first on our agenda. Next slide, please.
Sorry, I wasn't sure if you were ready for me to take it away, and then I couldn't get myself off mute.
I had that trouble too. I think this is one of those mornings when the technology is not as cooperative as we'd like. Please go ahead, Dr. Jobe Shields.
All right, great. I'll go ahead. You can go to the next slide. Great, thank you. So I'm going to provide some background and overview of the Marcus Alert. Harvey from DCJS will be helping out at that as well. And then we will hear from 2 local implementations of initial areas, Virginia Beach and then Prince William County. And then we'll wrap it up. Harvey will wrap us up with some kind of things to look for the next 6 months or so. But we're hoping to have time for questions and discussion. So we'll try to move through it so that we have time to hear what you all want to talk about. Next slide. All right, so the Marcus David Peters Act is named in honor of Marcus David Peters. He was a young Black biology teacher. He was shot and killed by police in the middle of a mental health crisis in Richmond. And it was passed during special session of 2020. So I note that because it is in a little bit of a different timeline than some acts that usually pass in regular session. And there's a picture there of some of the family members of Marcus David Peters. It was strongly advocated for by them. And it's a very complicated piece of legislation with a lot of different pieces to it. But overall, it's about trying to provide a community-based behavioral health response when there's a behavioral health crisis. Next slide. So the first thing that we had to do is we had to write a state plan with required input from a number of different stakeholder groups at the state and local levels. This was due July 1st, and I think we made the deadline. Might have been like midnight or something, but we finished the plan July 1st, and to do so, we had a stakeholder group that met over about a 6-month period. We also had some public listening sessions and things like that. And then you can go to the next slide that I think has, so this is kind of where the plan is. So there's a 20-page version. That's the best way to get an overview. There is a longer version, and it has sort of a full catalog of kind of every different service related to this that's currently, that we know of, that's currently available in Virginia. But in general, the state plan, it is broader than just the local requirements. When you read the Marcus David Peters Act as a whole, it includes things at the state level, like mobile crisis team rollout through Step Virginia, and a lot of things. So there's kind of the larger act, and then there's these local components. Sometimes we call that part the local Marcus alert. And those are requirements that are on the locality. So that's kind of how we break it up, so that when we're talking about the different pieces, we know whether it's something that the state is trying to organize and get out there versus a requirement on each locality. Next slide. And, when it comes to, Virginia is definitely not the only state that is looking at this, that's trying to, really build a behavioral health response system that decreases our reliance on law enforcement as first responders. We're not the only ones doing that. And so there's a lot of movement going on in a lot of areas. And this is kind of how we see it in Virginia. At the federal level, there's 988, which is that 3-digit code needs to, at minimum, link to the National Suicide Prevention Lifeline by July 16th of 2022. But most states are really using that as an opportunity to get those 3 digits to get you to the full crisis continuum, whether that's mobile crisis or, what it is that's needed. At the state level, we have a single data system, a call center data platform that all 988 call centers will be utilizing. So it's often called sort of an air traffic control or care traffic control. And really the idea is that at the state level, you need that technological infrastructure so that, it's known where folks are and people aren't kind of falling through the cracks and things like that. At the regional level, Step Virginia has focused on, so far, children's mobile crisis, but most recently has begun to start funding adult mobile crisis. And these are regional teams. They're co-located throughout the region, but they're all employed by hubs within the 5 DBHDS regions. They're specialized teams for youth, folks with developmental disabilities, and hopefully maybe other special populations in the future, but they're also all cross-trained, or the goal will be for them to be cross-trained so that we have people can respond to whatever the situation might be. And then at the local level, we have the Marcus Alert protocols and the coordination with local law enforcement, as well as these law enforcement reforms that are going on. working with magistrates at the local level, emergency services at the community services boards at the local level, and then other first responders that are local. So they're kind of, there's pieces at each level, and the idea is really that they all need to coordinate to make this work. Next slide. And the broad model that Virginia is trying to move towards is it's called the Crisis Now model. It is very broad. It's not as detailed as like a specific evidence-based practice, but it essentially breaks down 4 elements of transforming the crisis system, and so it's a helpful way to think about it. And what it is it's someone to call, then they can talk to you on the phone. Someone that can come to you, in your home environment with your natural supports, in a reasonable amount of time. Which for the regional teams we're doing with Step Virginia, that's an hour. So again, it's not a 10-minute response. It's within an hour coming to you in person, and a place to go. So these are often called crisis receiving centers or crisis stabilization units. It's kind of essentially what we currently have as CTACs. It's kind of that along with other services like crisis stabilization services, and they can all be part of one, entity, or you want to make sure that your community has all the different pieces between, law enforcement drop-off, 23-hour observation, peer support services, and then, residential overnight beds. So those are, and then the essential principles and practices. And one of the essential principles and practices is coordination with law enforcement. So we feel like overall the Marcus Alert requirements are really consistent with this model that we're trying to move towards. Next slide. So these are the first 5 programs. These are the initial areas, and these were all areas that were motivated to engage in this. They showed interest, met some base requirements, and really took this on as pilots. And so, there's a lot of unknowns because it is a really big implementation. But all 5 of the initial areas, these are all areas that chose to be at the front of the line. So, and you'll be hearing from 2 of them today. Next slide. All right, I think so. After this, I'm going to pass it to Harvey. These are the 5 state components of the law. Sorry, not the law, the implementation plan. So again, these are things where there's some level of, state agency responsibility to make sure that, we kind of have everybody doing the same thing. First, there's a 4-level framework for urgency, which essentially equates to we're asking everybody to define situations as Marcus Alert level 1, 2, 3, or 4. There's the mobile crisis teams that are on a regional basis, and then there's corresponding Medicaid rates that start December 1st. There's an Equity at Intercept Zero initiative that is to fund Black-led, peer-led, and BIPOC-led projects that are related to crisis services across the state. The statewide training is at a state, the training, we've placed that at a state level to make sure it's integrated in with the general law enforcement training and general mobile crisis training. And then there will be a level of marketing at the state level. And that's really because as far as the message we're trying to put out, we really need people to call 988, and we need them to call early, right? When the crisis is early, before it's a really emergent situation. And so really the marketing piece of it, there will definitely be a lot of local outreach to make sure folks understand how things work. But at the state level, we're going to be advertising really the concept of, call 988. Again, it doesn't mean someone's going to come right out, right? They're going to talk to you on the phone, and, it doesn't have to be a huge emergency to make that call and get the support you need. So I'll pass it to Harvey to go through the local pieces.
Great, thank you, Lisa. Everybody hear me? I think so. All right, cool. So there are some local components to the Marcus Alert programs. First of all is the voluntary database. The voluntary database was legislation that mandated that localities offer an option for persons to self-report themselves to the locality as having a mental health need, and provide additional information for that locality to then provide to emergency responders, whether they're police, fire, or anything else. The locality-driven voluntary database does have some shortcomings, but it is a key first step in making sure that those that wish to have advanced information out to emergency responders have that opportunity. One thing that is important to note, the legislation did not mandate a mechanism for what that voluntary database has to look like. There are some technological, very advanced and very expensive, frankly, technological answers to the question of what that voluntary database has to look like. There are also some not so expensive options for this, especially in smaller localities with lower call volumes that might meet the legislated requirements of the voluntary database. If that's something you're exploring and have additional questions about, we can talk more about that either offline or at the end of this. There's also a significant investment in local planning groups, including some of the key stakeholders that would be part of mental health response, including law enforcement, obviously CSB systems, emergency communications, and then lots of other stakeholders are brought into that, including citizens of the localities to help drive how this is going to look. There's a local component to the triaging network and the 4-level framework that has also been laid out that is important to be discussed and determined at the local level. How is your CAD system, your computer-aided dispatch for your PSAPs going to navigate those specific levels, and what are they going to look like on a call-by-call basis? There are several protocols that also need to be looked at. One of them is the transfer and the communication between 911 and the 988 system. Obviously, the 988 system is going to be a major realignment of how we as a society and communities reach out for emergency help. And so making sure that there's really good communication between locally driven 911 systems and regionally driven 988 systems and how they dispatch and interact with one another is important. There's also Protocol 2, which is the agreement with the Crisis Call Center. Protocol 3 involves a lot of law enforcement work and policies and protocols. This represents a pretty substantial change in how law enforcement's been doing business for the, recent past few decades. We have been law enforcement, I say we because I'm retired from after 25 years with RPD in Richmond. We were the de facto after hours mental health response. And there's no one in law enforcement that I've ever met that believed we were the best qualified to handle mental health calls for service. It's just that was something that was put on our plate. I think a lot of folks might believe that law enforcement would be reluctant to give up this part of their job, but I've met very few that are. And so realigning law enforcement policies and procedures and how they're handling calls for service is going to be an important part of this. Community coverage options are important, and we'll talk about that later. And then also finally, as we approach the July 1 of 2022, all localities are mandated to submit a plan on what their answer to being responsive to Marcus Alert legislation and the plans is going to be. Can we go to the next slide? Other community coverage, mobile crisis teams through Step Virginia and Bravo are going to be formed, but there will also be opportunities for local teams to also be formed. And there are a variety of different mechanisms that would, or a variety of different looks that the state plan allows on what that can look like. It can be a co-responder model where a police officer and mental health clinician are riding together, riding separately. And there can even be teams that don't include law enforcement, although that does come with its own share of challenges. But there are a lot of different options, and localities, depending on size, resourcing, and their own expression of what they believe their priorities to their community should look like, can embrace one of those. And those options are fleshed out in detail in the state plan. We go to the next slide. So I believe that next slide is going to cover some of the financial aspect. I'll kick it back over to you, Lisa, for this next slide.
All right. So, one thing when we're talking about the funding of the Marcus Alert, one thing that we always share is, the most expensive part here is actually building that behavioral health, like Harvey said, kind of after hours crisis system. We have our CSBs that provide the emergency services, but having, more staff, team-based responses, more vehicles, all of that, that is that's highly expensive, the call center platform and all that, it's really kind of building this whole new response. And so as you can see, we've had to kind of look at a lot of different funding sources there, but I would say that we're, generally optimistic about the funds that we've received, and that we are going to get there. So there's Step Virginia money. There's call center staff money where we have about half of what we need. So we do need to get there quickly on the call center staff piece. The dispatch platform, there's a new required set aside on our mental health block grant that'll put 5% towards crisis each year. This year we're putting much more than 5% towards it to try to kind of get started. There's the new Medicaid rates that are funded. We've got $7 million going out in one-time funds to build up these crisis receiving centers. That's not going to get us all the way, but that's going to fund, I think about 4 sites maybe. And we've also received $10 million in ARPA, the state ARPA funds. And so that's going to be split between mobile crisis and crisis receiving centers. And finally, Virginia was actually the first state to pass a 988 tax. It's very similar to your cell phone fee. The cell phone fee that's that everyone pays for 911. Virginia adopted a tax to support 988 because the call center, you can't really bill any insurance for that. It really needs its own type of funding.
There are other funding streams that are going to be coming in on this as well. The first 5 areas had a $600,000 initial investment. And we've also had additional state requests for ARPA that were not granted. I will mention from a DCJS perspective, though a smaller organization, and we did manage to get a substantial investment out of ARPA of $1 million for CIT. And that will go directly into CIT, with a number of different priorities expressed there, including a review of the CIT curriculum, additional resources for training for local law enforcement, because CIT is the de facto, as you all know, law enforcement training, additional resources for reviewing emergency communicator training to make sure that we have the best for emergency communicators when it comes to this new changes in Marcus Alert as well. There's a number of different things going on with that, but we do have an initial investment in CIT of about $1 million, and we're hopeful, we're led to believe there may be additional resources that are going to be available. So with that being said, I want to kick it over to some of our localities. We have Virginia Beach and Prince William County. So we'll start with Virginia Beach, and then I'll let Prince William County pick up. So Virginia Beach, I believe Ms. Hicks or Ms. Smith, are you available to pick up from here?
Certainly. Thank you very much. This is Eileen Smith. Can everybody hear me well? All right, great. So I just want to start us off for the city of Virginia Beach. First of all, I need to say that the team here has just been very dynamic, and it's not only been about Marcus, it's been over the last several years where they've been building up our crisis services and looking at how we do things with our local police force in a way that's pretty unique at times. And so we have an incredibly good relationship with our local police force. And Angie is really, really responsible for the facilitation of not only what we've done in the crisis arena, which helped us to build upon for our being a pilot site for the Marcus initiative, but she's taken this Marcus initiative on to a very high level in our city, bringing together many, many different agencies, and not just our police, but our 311, 911 center, and some other really important stakeholders. So I'm going to pass this presentation to her to talk to you a little bit about that, as well as what we're doing community coverage wise and our implementation plans. There she is. She's trying to get off mute. There we go.
There we go. Can you hear me? Yep. Okay, great. Thank you, Eileen, for those kind words and all of your support throughout this entire process. So it is really a pleasure to be with you all today. I would say that all of our partners in this process have really been dedicated from day one to doing the very best that we can as one of the first 5 sites. To us, it's really an honor to be in this position, and we're very optimistic about what it can mean, not just for our local community, but across the state. The entire Commonwealth will benefit from this long term. But it has been a lot of work. So we hope that the work that's been done by the initial 5 and certainly by the department will help those that follow from this. So I'll share a little bit with you about what's been involved with the Virginia Beach implementation planning so far. The first thing that we did locally was develop an internal steering committee, if you will. So it was really small, and it had some key leaders from the CSB and also the police department, because we needed a group that could kind of figure out where to go from here, you know, how to add some structure to the process and make sure that the right people were brought to the table. So we did that, and then we formed our initial stakeholders group back in March, and it's grown over time as we learned about gaps in our representation. The group now has grown to 24 stakeholders. We are looking to add a 25th probably really soon. And importantly, I want to share with you that it includes individuals with lived experience and also family members of people with lived experience. These individuals know what it's like to be in a behavioral health crisis, and they've been through the entire process of having both police and behavioral health responses. So their input has truly been instrumental because they see it through a different lens. And so I would encourage all communities to make sure that your stakeholder group has people with lived experience involved. Our initial stakeholder meetings were really focused on setting a foundation of knowledge for the members. So we did presentations on the legislation itself. We talked about the roles of the stakeholder group. And we also went into quite a bit of detail about the existing crisis service continuum in Virginia Beach, so they would know the point that we were starting from. And then from there, the group helped us to identify gaps in our system and ultimately decided how we should use the state funding allocation to expand our crisis coverage. And I'll talk about that in just a moment. As part of our budget proposal, the group also made sure that we had some funding available for community awareness initiatives, and they recognized the need to establish a community awareness subcommittee to focus specifically on getting that community engagement piece going. In terms of our community coverage, the stakeholders group decided to expand our existing mobile co-responder team. They felt that we needed longer hours of availability during the week, and right now we do not have any weekend coverage. And so the state allocation will allow us to expand that and offer the service on the weekends as well. And they chose that option because they felt that it was truly the most versatile option because it could be used in different ways with different levels of Marcus Alert. It could be used at level 2, 3, or 4, actually, just depending on how you want to deploy it. So it gives us additional options. In addition to expanding our mobile co-response option, we will also have regional mobile crisis response teams for both children and adults. And those regional teams will be responsible for going out in the community on crisis calls in Virginia Beach, Norfolk, and on the Eastern Shore. Moving on to protocol development. It's important to talk a little bit about this because it was quite a learning experience, and it involved numerous meetings with different stakeholders to really build the framework. For Protocol 1, our Emergency Communications Center, or our PSAP, in Virginia Beach, which for those of you who may not be aware, that's Public Safety Answering Point. They developed a standard operating procedure that outlined how the calls would be screened, categorized as a Marcus Alert level, and then gave instructions for how 911 call takers will ultimately complete the warm handoffs to the regional call centers. That part was very important, and our PSAP felt strongly that it really needed to be that warm handoff to make sure all of the information was shared. They have established a work group that will specifically look at how they code those calls in their CAD system. And this piece requires a lot of technical detail that is going to take a bit more time for them to finalize. But the foundation is there. They just need to work out those technical details. For Protocol 2, we facilitated, and by we, I mean the CSB side, we facilitated meetings with the regional call center, which for our locality is Western Tidewater CSB, and the decision makers in the police department and emergency communications center. Ultimately, through those conversations, an MOA was developed that outlines how the call center will communicate with 911 and alert police when we have a mobile crisis team in the field. So there's that notification there, and which should allow them to have some degree of readiness to serve as backup if we need it. The agreement goes into some additional detail about status checks to be completed within 10 minutes of being on site, and then every 30 minutes thereafter. And if for some reason the crisis team does not respond to their check-in call, or if they indicate that the situation is escalating to a higher level, then the call center will contact emergency communications, and they will dispatch police to provide additional support, hopefully stabilize the situation, and then continue with the behavioral health intervention. The MOA also covers some of the reporting and documentation requirements that you're probably less interested in today. For Protocol 3, our police department was heavily involved in outlining their training protocols for a specialized response, including policies that look at implicit bias, fair and impartial policing, and a number of other policies that really promote a specialized response. And they have over 13 policies already and a couple of pending that are really focused on this. I believe, and I'm a fan of our police, but they're really in the front of this and have taken this seriously for many years and are still looking to improve. They're looking forward to DCJS releasing some additional curriculum in the future that they intend to implement locally. There are baseline trainings that all police officers receive, and then we have about 50% of officers that are CIT certified. Our mobile co-responder team does have some advanced training as well. So all of that is outlined in our plan. In terms of, next slide, please. In terms of lessons learned, I would say that the most important lesson that we learned is to get the PSAPs and the regional call center staff involved early on in your process. I would go ahead and start having those conversations, making sure that everyone is on the same page. Also, as I mentioned earlier, make sure that your stakeholder group has people with lived experience because they see it through a different lens, and they will help us get to a better place with this process. Also, I would strongly recommend that you establish a community awareness work group to help you organize your community listening sessions or other types of public forums that you plan to do to gain community input. If I had it to do over again, I think our stakeholder group and my partners here would all agree that we wish we would have done our listening sessions earlier. It just took us a bit to get organized around it. If we would have had that community awareness work group, I'm sure it would have gotten us into that place a little sooner. So with that said, I will turn it back over to Eileen to share our next steps in Virginia Beach.
All right, thank you very much, Angie, and thank you so much for all your hard work. It's been a full year's work in just a short period of time, it seems. So right now, the team here in Virginia Beach has been looking to submit our local plan, which is due. All the regions who are participating in this have a local plan that is due next week. So we are finalizing that right now, making all the final changes, and we'll be ready to submit our plan. We're also trying to hire and train the Marcus Alert and the mobile crisis staff. As you know, it's extremely difficult to hire right now. And so we're trying to find some qualified individuals to be a part of this team. And our positions are advertised. We've gone through our normal city processes with that and are trying to do the best that we can to recruit the best talent we have here in Virginia Beach. We're going to develop and are continuing to look at data tracking mechanisms. We will have to provide data on what's occurring. And so therefore, that is a key part of this, to make sure that you're keeping data right from the start so that you can report back and forth with the state on what is occurring and your city, because you're going to want to give your city reports on your partner initiation here. And so many different reasons to collect data and keep it fresh and always available. Continuing to do the stakeholder and community partner meetings. Angie's been just such a great champion of this. As you can tell, she really believes that we need to have a lot of people with a lived experience involved in that, as well as your other experts in the field in your city to help guide that process. So she's done just an amazing job of facilitating this for the city of Virginia Beach. And then finally, just launching community education and awareness initiatives. And that's all a part of this. You want to make sure that your community knows what's going on. They know who to call. They know how to get that service, and that they feel more comfortable with understanding how your CSB or your locality is managing this. So again, I'd like to thank the team here in Virginia Beach, and then I will pass this on to Prince William County. Thank you. You're muted, Lisa. Just a second, they're still trying to unmute in Prince William.
Can you hear us now? Okay. Can you hear us now? Okay, thank you. Prince William is very pleased to be a part of this panel today, and definitely to be one of the implementing areas. Although actually it was an easy sell for us, because our county had supported the institution of a co-responder program in November of 2020. And Heather was passionately leading this effort. So when Marcus Alert came along, some of the relationships that had already been developed were in place. And Heather has been the Marcus Alert lead extraordinaire. So I'm going to have her explain a little bit about our project, but I did want to mention, you'll hear some similarities between us and Virginia Beach, but there are some differences as well. And one was, we started with two stakeholder groups. One we called a mission group and the other an implementation group. And Heather has been leading that implementation group with our county and city partners, really getting the boots on the ground and getting into the protocols almost immediately. And in March and April, we sent out, we had an application process for our mission group, because we really wanted the members of this group to be representative of our community and really give voice to what we're doing and have that exchange of feedback. We received over 50 applications for this group and selected 28 members, really based on lived experience, having a behavioral health disorder, being a family member of someone that does, having experience with developmental disabilities, having experience with the LGBT community, with being arrested, with going through the crisis system, with being a strong advocate for social awareness and various other aspects to really connect with our community. and the group's been wonderful. We've also crossed them with our implementation team so that we have representation for both teams. But this mission work group will really be getting our plan to the community and providing feedback beyond December. So I'm going to turn it over to Heather to talk a little bit more about the two groups and our protocols.
Yes, thank you, Lisa. So this has been what we've been living and breathing. I imagine Virginia Beach is feeling the same over there. We've been living and breathing this for the last year. And it's been wonderful. As Virginia Beach mentioned, we also find this to be an honor to be able to be an implementing area. So we, like Lisa said, already had some of these relationships that were already there. So I'll start with the mission team that Lisa's already talked a bit about. The goal of that mission team was to be able to have communication with the community and be able to get their feedback to let us know through their lived experiences, through the people that they represent, what are the things that are needed in our community. And a survey went out to research a lot of that information, and that through that group and through their connections within the community to be able to get that information back. And of course, what we found, which I don't think is a surprise to a lot of CSBs, is that our community doesn't know what crisis services are being offered. And so we knew very quickly that we've got to get out there and figure out how to get that information to them. And that mission group is going to be the crux of that, the ones that are going to be able to help us get that information out to the community in the best way possible. It was formed, of course, for Marcus Alert, but it is not going to stop. It's going to keep going so that we can continue to get that information out there and get their feedback on what needs to happen. From those surveys and from the mission group, we found that the community does believe that co-responder models and mobile behavioral health responses rather than police are the way to go. They also believe that having a crisis receiving center in our area would be of help to them as well. So those are all things that our county is looking into based off the feedback that we're receiving from them. So the implementation group, that was your people who are having to implement this on a policy level. So that was police, fire and rescue, PSAPs, as Virginia Beach mentioned, is our emergency call centers, as well as magistrates and local hospitals. We had representation from all of that. And of course, CSB led that initiative for the implementation group. We already had such relationships through building our co-responder team and many other initiatives within crisis within Prince William. So that was a very easy group to put together. The main advice I give in that is that anyone in that group really needs to be decision-making people. So it doesn't just need to be a representative of those areas. We need to have decision-making people in there. So the level of police that I had were a lieutenant or above. I had the chief magistrate. When it came to fire and rescue, I had there's the training aspect. The people who are in charge of the training of fire and rescue were in there. So people who can make decisions, and they were passionate and they wanted to make it work. I actually was in awe of their just extreme willingness to say, yes, we'll do this. We want to make it happen. You tell us what we can do, which was amazing. So through that, we've been able to develop the policies and procedures and protocols, which I'll go into in a minute. But that implementation group has been really the center of being able to make that plan that we have to submit in the next week. We focused on the protocols. We focused on really digging into what is currently there. Because when you're looking at Marcus Alert, you have to figure out what do we currently have and how do we take what we have and meet the requirements and make it better, as Marcus Alert is really pushing us to do, which is a great initiative. So our police departments were very open about their policies and their procedures and everything they had in and where they could add things and where they could change things. So I'll go into that with the protocols. So I think those two teams have really been the best thing for us. We wanted to do it separately, mostly because we wanted to keep the initiatives of those two teams at the forefront. And we felt like the community feedback and then also the policy and procedure, one didn't really outweigh the other. We felt like they both needed equal attention. And so we wanted a group that would focus on the community feedback and another group that would focus on the policies and procedures. But the communication flows between those two groups. So it's not a matter of us working in silos. It's also sharing what we're doing across those two groups. So with the protocols, Protocol 1, our PSAPs have been amazing. We've done a lot of training across Prince William County. I've gone in and done some foundation training with our PSAPs, and I think a lot of areas might find this, that a lot of the dispatchers don't really know what's offered out there, and they're the ones answering the phones. So we're out there doing a lot of training with them, gone to every one of their squads and said, this is what community services is, this is the crisis services we provide, and here's what Marcus Alert is and how it's going to affect you guys. We did that before the final draft came out of Marcus Alert. So now we'll be going back out to talk about the triage levels. Now at their leadership level, we've talked about all the triage levels, how they're going to transfer those calls. That has all been put in place. They've agreed to use the poison control model, as most of the state has, to be able to transfer those calls in a seamless way where they're staying on the phone. It's a warm handoff, as was mentioned before, because that's really important. I think Marcus Alert points that out in the legislation, or in the plan that was put out, is that you need to be able to stay on the phone and to determine where does this need to go. 988 in the call center is going to be doing the behavioral health side. 911 is also going to be dispatching fire and rescue and police. So if both are needed, that's why that warm handoff is needed, so that they can make a decision on, do we need to send both out? Do we just need to send one of these out? So they have put that in place. They'll be training all their staff. They'll be putting in their protocols, and we're pretty much, I would say, in the same place that Virginia Beach is with this. The only piece that's really hanging out there for us is the CAD system, because that is very intricate in technology and how that they can go in there and set their data to collect things. I've learned so much through these groups about how all of these entities function, and one of the things I learned is if you mention the CAD system, they go, so it's not an easy process for them to go in and do that, but we've set in, we know what data points we want. We know what data points we're going to have to collect. We need to be able to say when a call comes in, this is what level it was triaged at, this is what they did with it, if police or behavioral health responded, how that response went. So that will all be implemented by December 1 into their CAD system so that we can collect that data, and then also have the ability to transfer calls. Where Virginia Beach is way ahead of us is Protocol 2. We do not currently have our call center identified. We are in the RFP process, which means we are currently selecting the vendor for our call center. This means we can't put pen to paper, we can't put signatures on an MOU. However, our regional director at the regional office, Jean Post, has been amazing, and she is putting together that MOU. For when we get the vendor identified, we can put pieces in that need to be identified and get that rolled out. What we have learned with this MOU is in Prince William County, I have 3 PSAPs, I have 3 different police departments, and I have 3 different entities of fire and rescue, all of which have to sign this. And if you can imagine how many attorneys that is that has to read this and look at this MOU. Luckily, the state gives us 12 months for implementation to get that up and running, thank goodness, to get it signed. I think the writing of it is not going to be difficult. Jean has done a great job of already putting together kind of a rough draft for us and getting all that together. What our regional director decided to do, which we were really happy about, is the call center will have one overall MOU with each locality. So we will have one MOU for Prince William County with our call center that each of those entities will sign on to. We felt like that would be a lot easier than having 12 different MOUs with different areas. We also have our regional response teams. We do have regional mobile crisis, which is provided to us through REACH and through CR2. CR2 will provide that across all lifespan. Right now they only serve children, but they are expanding to all the lifespan ages. And REACH responds to the intellectual disabled and developmentally disabled populations. So we will have our regional teams that we're going to be able to use. However, we have also included local teams with the money that we've received. So those local teams that we have, one is our co-responder team, which we already had going before Marcus Alert came to be. Our county, our board of county supervisors, approved us to have 3 clinicians and 3 officers who ride together all the time. That's their only job. They ride together every shift, and they respond to persons in crisis. We have moved away in our law enforcement and just in county rhetoric altogether, from from trying to identify someone as purely just mental health or purely just substance use or anything like that. We just use the term person in crisis, because that could be absolutely anybody. Our team does not have to respond to just a mental health situation. Any person in crisis where they could benefit from having that clinician and that CIT officer, that's where they go. We are able to expand and add 3 more in January that our Board of County Supervisors had already approved, which is amazing. That'll give us 6 teams. We cannot do 24/7. We're not on the weekends yet. We hope to expand to the weekends with another expansion soon. Then with the $600,000 that we were given, of course, there was the Marcus Alert coordinator that is a requirement of the state to have. We were able to use the rest of that money to hire what we're calling an outreach and engagement team. So that outreach and engagement team is going to be doing mostly level 1 and 2 responses locally, but also I think the bigger piece that we're looking for is this follow-up, which is where we found the gap. This is the gap that we felt like was the biggest in Prince William, and this was agreed on by the team and the implementation team, that you have a group of people that they're not walking in the door seeking services. They're not following up often with services, or they get out of the hospital and they don't really know how to connect to those other services. So we want to be able to follow up. That team will take referrals from fire rescue, CSB, dispatch, as well as police. They're non-emergent referrals that are just requesting outreach to people in the community. It could be a phone call, it could be in person, it could be anything that person would want. And it's really just to help connect them to services, be involved with them, help them with whatever it is they need, identify where the weaknesses are that are leading to the crisis, and help strengthen that and be very strength focused and helping build that for them and get them to what they need. And our hope is that that will fill a gap. That's only 3 people for our 500,000 population. So of course it's the beginning, and our hope is that that will expand. But I think that's something you keep in mind when you are implementing this, is this is just the beginning of what you're doing. And you may not be able to provide as much across the area as you want to, but you're starting it, and that's where it matters, is to get it going. So Protocol 3, our law enforcement agencies have been amazing. They already have a lot of the trainings that are being required. They are going to implement mental health first aid into the academy. We do have 3 different police departments that go to different academies. They have actually decided to work together because it's easy to, it's easy to say, okay, in the academy, we'll start providing this training. But what about all of the officers that are already out there? And how do you get those officers trained? So they're actually going to work together, all 3 agencies, to try to do that training together, so that no one agency is left with kind of that burden of trying to get their entire department trained, that they'll do that together. And we had already, in the academy, had an 8-hour CIT course that was already occurring at Prince William Police Academy. They're just going to replace that with mental health first aid. So that all the officers will have a basic knowledge of responding to those situations. They also identified a lot of protocols where they felt like they could focus more on some of that response. An example of that is their use of force continuum and de-escalation responses. All of them have a no force first type of de-escalation use of force policy. And we've submitted that with our plan to be very transparent and make sure that everyone knows, what those current policies are. But they have found in their policy at Prince William that they do acknowledge that their officers should take into account known factors such as the level of offense that has occurred. So the use of force should not be an over response considering what the criminal offense is. An example is, are you using force on someone who's running from you because they had hot checks? So they have a little line in there that says that they should give consideration to known factors such as criminal offense. We have asked, and they've agreed to add in there, that one of the known factors that they should take into consideration is somebody's mental status in that moment. And so they are happy to do that. That's just one of the policies. We already had some person in crisis policies that we had revamped recently because they all said emotionally disturbed person, and none of us liked the term. So we had already revamped some of that, which is how they respond to persons who are in crisis and might need to be detained or taken into custody or taken to the CSB. So we have revamped that to have better terminology and be more inclusive. The trainings, we also have that in our plan, of course, as Virginia Beach. This is a lot of what Virginia Beach said too. I think it's very similar for our police, is they have a lot of implicit bias training that is already a requirement of their police officers. They feel that, I think it was biannual, and I think they feel like they'd like to turn that into an annual type of training as well. So there's consideration as we looked into what is currently there. Yes, they have it, it meets the requirements, but they feel like they could do better, and they'd like to implement something more often that would address some of those things better. So I think, is there another slide for
The next steps,
the next,
yeah,
the next steps. Can I get the next
So
slide?
I want to just interrupt really quick. We only have about 4 minutes left.
Okay.
And if we want to have time for questions, I just want to kind of let everybody know that our time is almost up for this session.
Okay, and I will say that a lot of ours is exactly the same as Virginia Beach, so I can just go through that very quickly and say we will continue to develop our teams, collaborate with our region to get all our MOUs together. Lessons learned, a lot of what Virginia Beach said, strong relationships are important. And then we've got to get our plans submitted next week. That's everything we're working on right now. And keep the awareness and the marketing. That's really going to be our big push after we submit that plan.
All right, if we can go to, thank you guys both. I like the terminology of person in crisis. So I think that's my big takeaway. I think that's I haven't heard that mentioned before, at least in some of these forums. Good stuff. Can we go to the next slide? Oh, well, I'm sorry. Go back to the what's next. I'm sorry. So we're forming a evaluation task force. There's a lot of information on this. I want to please save a little bit of time for some questions here. Look for an upcoming conference at the beginning of 2022, COVID permitting. We would like to have a conference which we can have more of a sit-down conversation with the individual 5 localities and go into more detail on these things that were talked about here, lessons learned. Next slide, please. A lot of coordination and cooperation, state and local, within the local levels. We are building an airplane in mid-flight. This is a lot going on simultaneously. We recognize there's going to be some challenges for everybody, but it's very clear that from a mental health side and from law enforcement, we really recognize this as being critically important. Next slide. There's the contact information for the folks over at DBHDS as the point of contact for Marcus Alert. And that's a lot quicker of a summary of 3 slides than I thought I was going to do. So I'm sure I missed a lot, but I will throw it open for questions from the general group.
Yeah, I'm sure all of you join me in thanking the panel for so much wonderful information about the Marcus Alert effort and the implementation for 2 of the localities. One question that we have in the chat is, what is the recommended percentage of CIT trained officers? Does anybody have a recommendation?
This is Angie. I don't know if Harvey wanted to speak from a state level or not, if there's a state expectation for that. I can speak to what Deputy Chief Dean's goal is in Virginia Beach. He always strives to have greater than 50% CIT trained. And some people wonder, well, why 50%? Why not 100%? Well, with the turnover in the police department, that's impossible to achieve on any given day. So there is some turnover. And you also want officers that that want to do it. They're voluntary and they have a passion for it, because you don't want an officer responding to a behavioral health crisis if it's not in their DNA to do that. They could make a situation worse. So for us, it's 50% or more.
And I believe there's a national standard, Harvey, you may know that. I think it's like 23, 26% is the national CIT standard.
Yeah, yes, those numbers move all over the place, and I would really turn to Patrick Halpern with CIT Virginia to see what he recommended. But the key is to have it be more than 0, right? And we have some agencies that are poorly resourced across the Commonwealth, and smaller agencies that don't have the flexibility and training time that don't have any CIT trained officers. And that's just, that needs to be addressed. And I believe that the funding into CIT is going to find some mechanisms to try to overdo that.
Thank you very much. And I'm also wondering from our localities whether or not your local governments were willing to contribute ARPA funding to your efforts so far, or do you expect them to?
That is not happening right now in Virginia Beach.
Okay.
Not so much for the Marcus Alert because of the co-responder program that they have contributed to and continue to do so. The county is looking at that from a crisis receiving center perspective and making that a possible request for the ARPA funds for startup.
Okay. Thank you very much. I do not see any other questions in the chat. There are some comments regarding your efforts with your community advisory groups and stakeholder groups. It seems that our attendees are very impressed with your efforts overall on that. Obviously, this whole initiative is very intricate and a total system reform. And I have to say that it's extraordinarily important.